Hi, my name is Tiffany Harper. I am going to present my evidence-based project proposal on reducing pain in burn patients with the use of virtual reality. Little background on the burn patient population. Almost 500,000 burn injuries are sustained in the United States alone every single year. Inadequately treated pain related to those burn injuries contributes to loss of faith in providers, poor compliance with care, chronic pain syndromes, post-traumatic stress disorder, and even an increase in suicidal ideation. The American Burn Association has developed guidelines on a multimodal approach to pain control and management. It includes things like long-acting opioids, short-acting opioids, benzodiazepines for anxiety, gabapentin for nerve pain, as well as your over-the-counter drugs like ibuprofen and Tylenol. ABA also suggests that adjunct therapy should be offered to burn patients, though they don't specify a specific strategy or make recommendations as to what types of adjunct therapy. This presentation is going to propose the use of virtual reality as an adjunct therapy for the adult burn population in efforts to reduce pain during painful procedures. So your wound care, physical therapy specifically. I will identify the significance of the practice problem, identify the PICO question and answer, as well as the search strategy that was utilized, and a synthesis of current literature related to virtual reality as an adjunct treatment. So a little bit about the practice problem. So patients who sustain burn injuries experience an intense and immense amount of pain, despite those scheduled medications that follow the ABA guidelines. And that goes from the onset of injury through the recovery phase. So the entire continuum of care, it's found that it's difficult to manage pain. Uncontrolled pain can lead to physical and emotional setbacks that will actually prevent a full recovery from the initial injury. Some of the procedures that these patients might endure include their debridement, their daily wound care. Sometimes they need wound care more often, several times a day, depending on the depth of the wound and the severity. Physical and occupational therapy, and some patients do require excision and grafting in the OR. All of these interventions induce pain on our patients. Not only do we have to worry about the patients themselves, but we also have to consider the families. Often these patients go home before they're fully healed, and the families are left to care for patients that now they're inflicting pain. So families are left to care for their loved ones, often put their needs aside to focus on the patient themselves. They worry about things like inflicting pain. They worry about how their surviving loved ones will actually return to society and function normally given their body changes and appearance. As well as all of the psychosocial factors, there's a cost factor. So in a 10% TBSA, or total body surface area burn, so 10%, those injuries can actually cost upwards of $270,000 because on average, those patients are having a length of stay inpatient of about 18 days. Burns are special. They're often transferred from a small community hospital or even a central, larger hospital to a verified burn center so that they can receive appropriate treatment. A lot of times these can be hours and hours from their home location. So readmissions are a concern because of pain. Most of them are coming back with a complaint of pain, but our readmissions aren't necessarily being captured because they're not going back to the same facility as they were treated for in the beginning. So just to kind of make a point that we're not necessarily capturing all of those readmissions. So the numbers that we see in the research may actually be a little bit less than what's actually happening in that regard. Appropriate pain management in general is linked to positive patient outcomes. So promotes wound healing, patients get better sleep, they're more likely to participate in their therapy, and they have an overall improved quality of life. So my PICO question, in adult burn patients, how does virtual reality therapy compared to pharmacological therapy alone affect pain levels during wound care and physical therapy? This was my search strategy. I started with an initial search in the USA Library, and I also did one in Google Scholar using the keywords burn, pain, virtual reality, VR. I did use the acronym, pharmacology, and I did actually, I think, use the term adjunct therapy. This yielded over 20,000 results, way too many. So I added a date range filter, dropped it down to the years of 2017 to 2022, and this brought me way down to 435 studies. Of those 435 studies, an additional 412 were excluded. A lot of research has been done in this area with pediatric patients. So those studies were excluded, as well as studies conducted outside of the United States. Wanted to be as close to our actual patient population as we could. And then the primary research studies included 8 studies, 5 quantitative and 3 qualitative. So my synthesis of literature is going to come from those 5 quantitative studies, but since pain is subjective and there are many ways to measure it, it was important to me to include some qualitative studies when I was conducting my own research. Each of the studies was evaluated using the Joanna Briggs critical appraisal tool to assess validity and reliability, and then given a rating using the Johns Hopkins rating scale. This slide is just the copy of my Prisma literature search diagram that puts a visual format to the information I just shared with you, how I got down to my final 5 quantitative studies, and then some of the other reasons that studies may have been excluded, including an outcome that didn't align with the PICO. So if it was looking at anxiety versus pain, or if the intervention did not align with the PICO, because when you search adjunct therapy, things like yoga also come up, or exercise, or even things like walking as an adjunct therapy. So we wanted to make sure that all of the interventions studied aligned with my PICO question. So what did the literature tell me? Most of the literature identifies that virtual reality is an effective means of reducing pain in this patient population, in addition to the pharmacological guidelines for managing acute pain in burn patients. As I mentioned earlier, the ABA, or American Burn Association, does suggest that in addition to the multimodal pain approach, that all burn patients should be offered adjunct therapies, though again, there are not specific suggestions in their guidelines. McSherry's study took it a step further, which I found really interesting. So they not only looked at pain levels, but they also looked at how much opioids were used during wound care when virtual reality was applied. So all of the patients received their regularly scheduled opioid narcotics. However, he took a step further and said, okay, let's measure how much breakthrough pain was being treated when this intervention was applied. So I thought that was an interesting approach worth noting. Most of the studies reported significantly less pain with virtual reality applied. And then Scheffler actually stated that the application of distraction leads us to conclude that pain is largely cognitive. So I thought that this was interesting to point out. So if we can distract our patients and bring their attention to somewhere else, oftentimes we can deter that pain. One more theme that was identified, not necessarily related to pain, but how a positive experience can actually promote pleasant memories that reduce anxiety and increase compliance with care, going along with that thought that pain is largely cognitively controlled. So Soltani, probably one of my favorite things that I read, that said even if reduced pain is not translated into immediate results, he was specifically talking about range of motion with physical therapy, that less pain leads to collaboration and more participation in care. I did go ahead and include the synthesis matrix that was provided in my written proposal, just showing how all of the quantitative studies do align and their perspective on the main ideas identified. So how am I going to apply this in the clinical setting, and how am I going to evaluate and measure my outcomes? So we are a verified burn center where I work. I work very closely with learning specialists and educators, as well as our corporate education team. So it'll be really easy, actually, aside from purchasing the equipment, which luckily our specific burn center has a lot of donors. So with the right proposal, this could actually become a reality, which is cool. So what I would measure, I'm going to look at my patient-reported pain. So this would obviously be in an inpatient setting where my patients are stable enough to communicate with me, because I'm not going to be able to apply virtual reality per se to a patient that might be intubated and sedated. So I'm going to want those walkie-talkie patients that can give me a pain scale using the 0 to 10 scale, or a pain score rather, using the 0 to 10 scale. I also would love to do like McSherry did and measure how much opioids are given during treatment for breakthrough pain, and is there a significant difference there? So all patients would receive their regularly scheduled pharmacological therapy. The amount of opioids administered during their painful treatment would be measured. Another tool that's pretty cool that we have for the burn patient population is the burn-specific pain anxiety scale. Not used so much in the research studies that I identified, but something to possibly consider as well. Both the patient-reported pain scale and the opioid equivalents are going to provide me with that numerical data, adding to the strength of the study. I would use the t-test for evaluation. This would be my preferred tool. According to Ali and Basker, the t-test samples are randomized, observations are independent of each other, so this is going to give me the most statistically reliable results. So to conclude, adequate pain control in the burn patient population, it's difficult across the entire continuum of care. So if we can control pain better, then we can offer better outcomes to our patients. We know that the American Burn Association does offer us guidelines for medical management, and while they say that all patients should also be offered adjunct therapy, we have no guidelines as to what the recommendation is. The research, as provided through my synthesis, does tell us that the use of virtual reality can aid in reducing pain, and it sounds like in more ways than one. So the PICO question is answered, and yes, virtual reality most likely could aid in the reduction of pain in acute burn injuries when used as an adjunct therapy. And a list of my references. I hope you enjoyed the presentation. Have a great day.